This program is brought to you by Emory University.
Welcome to the first talk of this academic year, Heart and Vascular Grand Rounds. I'm going to pass the rights to introduce the speaker over in a minute, but just wanted to welcome everyone and let you know that this year, Gautam and Pooja, Dr. Kumar and Dr. Mehta, are doing all the organizing. They've put together a full schedule for us this year. We really appreciate their efforts because it's a lot of work, but they've got a really great set of speakers. You know, this is pretty impactful if we look at our data. Chris gave me some data last year, and I forgot the actual number of downloads was like 14,000 or some huge number, right? Some big number like that, but 40 countries throughout the world. And an interesting distribution, we'll share that at some time. But you know, a variety of countries throughout the world are downloading us off of YouTube, and then a you know, huge number of people are actually watching these for CME, getting their free CME. So it's a very impactful series, and many thanks to Chris for coordinating all of the electronics parts of it, making sure these things work, and vastly simplifying the process to make things move forward. And with that, I'm going to pass it over to Gautam, who's going to introduce our speaker.
Thank you very much, Dr. Taylor. Good morning, and again, welcome to the first session in this series. It gives me great pleasure to introduce my friend and senior in fellowship, Kwan Lee. And Kwan is not a stranger to Emory, having trained here a year or so before myself. I think Kwan was in the same year as Michael McDaniel, whom we know. And I first met Kwan when we were both in Mayo Clinic as fellows. And Kwan has done some fantastic things since then, and I just want to summarize 2 or 3 of the what I thought were fun ones. So Kwan has been a great proponent of simulation, which has nothing to do with today's topic, and has been doing a lot of work with simulation in terms of cath lab simulation with the team at Mentis. So we're going to see a lot of news about Kwan. Secondly, he's also been significantly politically active within the cardiology political space. He's the governor of ACC in Arizona. And in the middle of all of this, he manages to publish and not perish, and also run a service line, and do a lot of administrative stuff, as well as good clinical work as well, in addition to managing 2 kids. So with no further ado, Kwan, please.
Thank you, Gautam, for that kind introduction. It's actually been 10 years since I packed those 2 kids into a van and drove across to Arizona from Emory and planted roots down there. So it's a real treat and honor to be back. Thank you, Gautam, for this invitation. Thank you, Bob, for having me here. And it's really good to visit with friends and mentors yet again, Habib. So this is a strange topic to start the year with. I've been pretty active with FSCAI and the International Committee, and we've been traveling around Southeast Asia and doing a lot of attempts to connect the 2 societies. And this year I was asked to give the keynote lecture in Malaysia at My Life. And I was very excited. I said, you know, what do you want to hear about? You want to hear about stent thrombosis, simulation in healthcare? They said, no, we want to hear about this exciting thing in America, physician burnout. I was like, okay, fine. Gautam was there. He saw the talk, and he thought it'd be worthwhile repeating here at Emory. So this will be the start to the year. I have no relevant disclosures except for the fact that I've taken the burnout test, and I'm not burnout apparently. You know, and that in itself is quite interesting. I'm a frontline clinician and have also had a chance to be at the front seat at the American College of Cardiology, the State Board of Governors meetings, and watch and listen to the concerns of our cardiovascular community in the United States. And physician burnout is a major problem, whether you think it's real or not. I think that's also an important question to address. So the objectives of today's talk are to appraise the quote-unquote epidemic of physician burnout and its implications as a public health crisis, to understand the evolving definition of physician burnout, to review the current literature on the epidemiology of physician burnout with a focus specifically on burnout in cardiology, is a field for which there is surprisingly very little literature. And then to review suggested strategies to decrease burnout. I have no solutions for you, but hopefully we can at least start to think about the problem and look for, clarity with what we do next. I thought it apt to start with this quote from Charles Dickens. This is the famous line from Tale of Two Cities. It was the best of times, it was the worst of times, it was the age of wisdom, it was the age of foolishness. It was the epoch of belief, it was the epoch of incredulity, right? For those of us who are optimists, we are poised on the precipice of a transformational revolution in healthcare with big data, with wearables, artificial intelligence, et cetera. But those of us who are on the front line of clinical care understand that, with such change comes great growing pains, right? We're being torn, kicking and screaming into this world. We struggle with this supposed, amazing revolution in connectivity with EHR, and it's for the most part, it's not delivering. We are disappointed on a daily basis. We are frustrated on a daily basis. And overall, the practice of medicine and cardiovascular, especially in cardiology, is changing in the United States. I borrowed this change management process, which comes from the world of healthcare executive speak. Time for change, and this is how you manage change. But we're going from the idea that we had, the ideals that we had when we first started and wanted to become cardiologists. Andreas, the history of this place, that autonomous physician making decisions, just living the joie de vivre of practicing cardiology and innovation, et cetera. And we're moving to this factory line of, this is a slide from Foxconn in China, and this is how an iPhone is produced, right? This is what we feel like on many days on the front line of healthcare delivery. From the center part of ourselves, with regards to autonomy and human connections, the thing that brings us to clinical cardiology, the things that drive us, right? We then, unfortunately, when we actually arrive, we are faced with the daily challenges of patients, of documentation, of finances, amongst the background of ACA, Joint Commission, macro quality, and all these other things, right? So this is from the MedAxiom ACC 2019 Cardiovascular Provider Compensation and Production Survey that was just released, I think, about a few weeks ago. And you can see that in the United States, over the last 10 years, time since I graduated from interventional cardiology, we have gone from pretty much 90% ownership model for practicing cardiology in the United States to less than 20%. We've gone to become employed physicians. And so the paradigm of what we are in the system of being an employed physician has completely changed how it is what we're supposed to be practicing. The median RVU production, and this big word of RVUs, right? This is a love-hate concept for many of us. By US geographical region, the South actually leads the entire pack, right? The median RVU production for cardiologists in the South is 10,744, which is a good 20% higher than the next leader from the West Coast for us in Arizona and California. You are the most productive cardiologist in the country by RVU standards. And whether that's a meaningful metric, it's hard to say. When you read the New York Times, right, you see the front pages are ablaze with these editorials, right? The business of healthcare depends on exploiting doctors and nurses. How do we take care of the physician? This statement such as, and I picked some choice quotes, physician burnout is reaching crisis proportions in the United States. More than half of US physicians are now experiencing professional burnout. Dissatisfaction amongst US physicians with how their time and skills are used is widespread and growing. And the highly trained US physician has become a data entry clerk required to enter a large amount of low-value EHR documentation. And one of the negatives of EHR has been the ability to push a lot of minor administrative tasks towards physicians. I just looked at my inbox yesterday and I had 450 tasks to complete. Renew this medicine, call this patient, et cetera, right? They have dismantled our support system and support structure and pushed a lot of menial stuff towards us in the effort of cost containment. By far, the biggest culprit, and this is another quotation from the New York Times, of the mushrooming workload is the electronic medical record. It's burrowed its tentacles into every aspect of the healthcare system, the giant kraken, to speak of the 21st century. In a factory, if 30% more items would suddenly drop onto an assembly line with all these additional tasks, the process would grind to a halt. Imagine a plumber or a lawyer doing 30% more work without billing for it, but in healthcare, there's wondrous elasticity, right? You can keep adding work and magically it all somehow gets done on the backs of our professionalism, on the backs of our dedication to our cause, right? As physicians overall, and I've had a lot of time to reflect on this, we are very smart, we are very used to adversity, we're tough, and it allows us to compensate very poorly, in the face of wrong change or bad change. Probably the best voice that has captured this era or this dissatisfaction amongst physicians right now is actually Z-Doc MD. He was an internist at Stanford and was a comedian on the side. His father was a first-generation immigrant from India, a primary care physician, and so his big sell is healthcare 2.0, how his dad practiced, to this whatever is in 1.0. 1.0 was how his dad practiced. 2.0 is what he describes the current state of how we are working and the dysfunction. And his vision for us is to healthcare 3.0. If you haven't heard or looked at him, he's been asked to be the keynote speaker at TCT MD this year, and he was the keynote speaker at the ACC Quality Conference this year, and it was phenomenal, right? He really captures that general zeitgeist of how we are feeling. And on YouTube, I think that's really how the world is measured nowadays, right? He has more than 2 or 3 million views. And this is probably his most famous video clip, his entire library of them. He's capitalizing on that, the most recent concept that it's not burnout, it's actually moral injury as to how we are feeling about what's happening and what we're being asked to do. And that statement actually comes from this article, basically equating burnout with PTSD, the moral outrage that we are feeling on the front lines as to what we perceive as this disconnect between what corporate America wants us to do and what we feel our patients should be getting, right? It's pure moral outrage. We are angry that we can't deliver what we feel should be, what we feel should be best for our patients. And the statement is this: physicians are smart, tough, and durable, resourceful people. If there's a way to MacGyver themselves out of this situation by working harder, smarter, or differently, we will already have done it. I would like to temper all this bluster, though, with some other thoughts, right? This is another New York Times article, editorial opinion piece, and the question is burnout real? Right? When a disorder is reportedly so widespread, it makes one wonder whether we are at risk of basically medicalizing everyday distress. Most people have experienced some of the symptoms of burnout, but they're persistent and impairing for only a minority of people. Does it make it a national epidemic? I think that's worth also considering. So as an occupational phenomenon, the term was first coined by Herbert Freudenberger in 1974 to describe the diminishing interest in work and loss of energy observed in volunteers at a drug addiction rehabilitation center. It's been studied extensively and worldwide, and it's basically found in all professional endeavors, police officers, pilots, etc. And the highest rates are basically found in professions with high levels of people interaction. As an example they give, the Roman Catholic priest burnout levels was 72% for those who were serving with parishioners, and 39% versus 39% of priests who basically live in secluded monasteries, right? The more that's being asked for us from our network, our community of people we interact with, the higher the burnout rate. WHO actually has it as a problem. It's very clear that it's not a disease by the WHO ICD criteria. And in the last version, the ICD-10, it lived under Section 21, factors influencing health status and contact with health services. Z70 76, persons encountering health services in other circumstances, blah, 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 burnout, state of vital exhaustion. There was an update for ICD-11 for this year, and this actually generated a lot of media excitement, although for the most part, most people who wrote about it actually got it wrong. They thought that ICD had updated burnout to become a disease, but it actually remains still a problem. Although there's been a bit more effort to flesh out exactly what it is that we mean by burnout. And they've dropped it into overall 3 dimensions: A, the feeling of energy depletion or exhaustion; B, an increased mental distance from one's job or feelings of negativism or cynicism related to one's job; and third of all, that also then results in reduced professional efficacy. And this is all a result from chronic workplace stress that has not been managed successfully. So what are the consequences of burnout? This is from Maria Panagiotti's group, who's probably one of the most prolific authors on burnout from the University of Manchester and the National Institute of Health British Research Unit. And this is a systematic review and meta-analysis of all about 45 papers overall on the effect of burnout on clinical care. They found overall that there was an increased risk of patient safety incidents, right? Of odds ratio of 1.96. There's poorer quality of care due to low professionalism, and that's about double the odds ratio, and reduced patient satisfaction, about the same. The effect is most pronounced in younger physicians and less pronounced in older physicians. What are the costs of physician burnout? This is also this is actually from University of Singapore. And Tate Shenenfeld, who is a major author in the world of burnout, originally from the Mayo Clinic as an oncologist, and I think it was Gautam's co-intern or chief resident, who's currently moved to Stanford and is taking that research there too. And they model some conservative estimates on US healthcare based on an increase in physician turnover and reduced clinical hours, and they estimate about $4.6 billion per year, or about $7,500 per physician in a healthcare institution, which is a vast underestimate, in my opinion. I think this is probably the paper that generated the most, or has been the source of much of the statistics quoted, and this from Shenenfeld, from the Mayo Clinic Proceedings. This year, they published a follow-up to the original paper, which was published in 2014 or 2015, that led to a lot of the burnout literature. But the methodology is pretty interesting, right? They surveyed 30,456 physicians. They got about 20% survey response rate. Fascinatingly, the most important tool for burnout assessment is the Maslach burnout inventory, and there is a 22-item survey. These guys reduce those questions to a single item question for 2 of the largest, and that's how they base this measurement of how many people out there are burnt out. They importantly surveyed the general population to ask the question of how many people are burnt out in general, and then they use that to compare it against physicians. And the overall general population rate is pretty flat in this modeling. It's 28%, right? In physicians, it went up from 40% in 2011, went up to about 50-something percent, 58%, I think, 54% in 2014. But in 2017, when the physicians, utilizing exactly the same methodology, were resampled, it dropped. It's actually fallen since then to about 40-something percent. But this is the paper from which you hear that statistic: half of all physicians are burnt out. Okay. So what are the pressures contributing to modern U.S. burnout? We've touched on most of this. Too many regulations, computerization, number of hours worked, healthcare reform, quality reporting, and this major shift from private practice to hospital ownership. The reality of modern U.S. medicine on the front line, based on EHR, and this is a graphic illustration from the New York Times as well, is most of us who have been to physicians these days, especially in those practices without scribes, have come face to face with this, right? You go in, you expect to talk to your doctor, and they're stuck staring at the computer screen, spending less than 20% of actual physical eye contact when you use eye tracking metrics they're not looking at you, they're looking at the screen trying to fill out your orders, right? Because a lot of people in primary care are being asked to complete that 99214 in 7 minutes on average, right? While filling out dictating your notes, putting in the orders, talking to you, and making diagnoses. I think this is an honest indictment, right? Glorified billing program with some patient stuff stuck on. It deprofessionalizes physician work and has a negative impact on work-life balance. On average, in primary care, for every 1 hour of time spent with patient, 2 hours are spent documenting in US practices. And many people, and in some people, the number is much larger than that, depending on how thorough you are with your notes. EHR and connectivity has actually allowed the tentacles to reach into our home lives, and many of us spend our evenings and weekends catching up now on our documentation. This is a phenomenon that I've noticed with, as an educator at University of Arizona. When I walk into a room with residents, in the old days, we used to see them on the wards actually talking to and examining patients. Nowadays, 90% of the time, you see them stuck in front of some EHR, documenting and creating these virtual patients, and I call it Tamagotchi care, right? These were the virtual pets that were very popular in the 1990s, where you kind of looked after the little pet by just pressing the button. When you look at the PubMed publication list, if you type in physician burnout, you see that the rise from 1986 in the number of articles very much parallels the adoption of EHRs, especially at stages 3 and 4 and above. As EHRs came into our lives, physician burnout, interest in physician burnout at the very least increased. Is it the cause, response? I think you could make an argument. This is more work from Tate Shannenfeld at Mayo Clinic, looking at clerical burden versus burnout, right? And they divided up into lots of into subspecialties, and there are 4 quadrants overall. Those are people who are satisfied with their clerical burden, and the percentage of people who are burnt out according to Shannenfeld's literature. And you can see that the front line is, once again, family medicine. This is a very consistent signal. Family medicine, emergency medicine, urological surgery, and urology and neurology. Cardiology, unfortunately, is not represented here. The people who are most satisfied with their clerical burden, because I think for them EMR is very straightforward, dictate a report and put the phone down, is pathology and radiology. Those people are quite happy with the amount of work that we have to do. But those of us who are asked to do complex tasks on EHRs, for the most part, are very dissatisfied with how our EHRs work for us. And the use of CPOE is associated with high-risk burnout and odds ratio of 1.3. What does the stage of career, how does this affect burnout? And once again, from Shannenfeld, you can see that burnout is actually highest in the middle career stage, quite prevalent. This is very disturbing, right? Because this is supposed to be the future. Our future cardiologists are for early career people, and they're already quite burnt out. And as you approach later career, this is not a longitudinal. This is just a cross-sampling of the state of how things are right now. Maybe it's because they see that the exit is close, and wow, I get to retire next year, so maybe I'm not so concerned about the question anymore. So part of the moral hurt that's been hoisted upon us, people say that, we have increased suicide rates, increased divorce rates with our physicians because of this. Is it true, though? This was an excellent paper from the Harvard School of Public Health, looking at divorce amongst physicians and other healthcare professionals using US Census Survey data. So I would say that this is probably the most accurate picture of the state of marital affairs, probably with regards to physicians. And despite prior statements that physician work demands leads to high divorce rates, one of the largest papers thus far actually showed that divorce amongst physicians is less common than other healthcare professionals and general population. So maybe some of these effects are not really that true. Divorce is actually much higher in nurses compared to physicians. The one signal, though, that keeps appearing in all of our burnout literature is this statement, though. Female physicians are 1.5 times more likely to get divorced, unlike their male counterparts. It's worth looking, I think, now that we've kind of laid the groundwork of where we are philosophically and where we are in the current in media, to actually look at the literature as to what exactly it is that they mean when they say that they measured burnout. The primary tool is the Maslach burnout inventory, right? It was first described back in the 70s, and they really codified their literature, and this is from Berkeley, Christina Maslach's group in 1981. And it has gone through many iterations since then, but this is the gold standard of how we exactly measure burnout. There are some alternatives, the Mayo Wellbeing Index, which is not very much utilized, and probably the Mini Z 2.0, which is from the American Medical Association, may be the thing that we should be using in the future, and we'll review exactly why that is. So the Maslach Burnout Inventory has gone through 4 editions. It's the most commonly used. There are 3 sections and 22 questions in this original guise, covering the fields of emotional exhaustion or burnout, depersonalization, and personal achievement, right? The 3 spheres do not correlate with one another. You can have a decreased sense of personal achievement, but not be depersonalized or emotionally exhausted, and you can be emotionally exhausted, but not depersonalized or not, and feel like you've done something worthwhile. If you actually look at the survey, it says there's disqualified at the bottom. This test is not intended to be a scientific analysis or assessment. The information is not designed to diagnose or treat your stress or symptoms of burnout, which is interesting for the gold standard instrument. This is why I think there's been a lot of confusion in the literature as well, because there are actually 5 validated versions of this. And there have been 4 editions. And they currently, if you choose to adopt the most recent version in literature, it's patented, and they charge you $50 per administration. And that's why I think there's some problems with it. The Human Services Survey, MBIHSS, was the original 22-item full-length 1981 version. It was then modified for medical personnel by replacing the word, I think something like a person with patient, right? And then they modified it for educators. I think they probably changed the word to student then. And then they've modified it as a general survey for occupations that are not involved in human services. And they changed some of that depersonalization with cynicism instead. And so there's been quite a bit of modification. And then there's a version for students as well. Looking at it, this is from the 3rd edition, and it's been compressed a little bit. Instead of having 9 points, there's 7 points, and I think it's worth looking at. You can take it yourself to try and figure out whether you are burnt out. These are the questions that they ask you for emotional exhaustion, and it goes from never to every day, right, on a Likert scale. And in the depersonalization section, I feel I look after certain patients, clients impersonally as if they are objects, etc. Going back to Shannonfeld's paper, they did a modified version even of this, where for those 2 fields of 9 and 7 items, they actually reduced it to a single item for both of those sections. In personal achievement, I accomplished many worthwhile things in job. I fulfill with energy, etc. Okay. This is the Mini Z survey that's actually proposed by the American Medical Association right now. I think it's been trying to move away from the complexity of trying to administer the Maslach Burnout Inventory, which takes about 15 minutes to do overall. And they've reduced it to a 10-question thing, and a lot of it are, I think, more focused and more pertinent to how we practice medicine. Sufficiency of time for documentation is. That doesn't really fall under any of your exhaustion or depersonalization, etc. So they're trying to make it a little bit more pragmatic. The amount of literature, though, around this is not as well developed as Maslach for obvious reasons. Probably the best paper, and this is from Lisa Rosenstein from the Harvard School of Medicine, and it's a tour de force of academic study. Her group basically tried to do a meta-analysis on the prevalence of burnout amongst physicians. They looked at 182 studies. They had 110,000 individuals across 45 countries across a span of almost 20 years. And ultimately, what they found was that within the literature, there were 142 unique definitions of burnout. The meta-analysis could not be performed due to heterogeneity. 86% of them used a form or some guise of the Maslach Burnout Inventory. And the overall burnout range was from 0 to 80%, right? The only conclusion they could really make was there needs to be a consensus definition and standardized measuring tools. This is a slide basically showing all or variance in exactly how burnout was characterized across the field, and point estimates based on the different methods of measuring burnout in physicians specifically. The accompanying editorial basically, said, there is clearly something important and worrisome happening with physician well-being. However, the self-reported symptom of burnout, often based on 1 or 2 questions, has rapidly become a marker for an epidemic of physician dissatisfaction described as a national crisis, right? The physician has become the patient, but the profession has started to act on the patient's symptom before there is any actual understanding of its pathophysiology, consequences, and effective prevention and treatment. And this is a little sobering, given all that we've heard thus far. This is another massive source of our burnout statistics in the media, and it's worth looking at. Even though it's probably the least scientific of its of the bunch of surveys, but 15,000 physicians across 29 specialties met screening criteria and completed the survey, so it's self-reported, right? Weighted to the AMA's physician distribution by specialty and state. About 300 cardiologists responded. Medscape repeats it every year. It's an online survey. It's obviously self-reported, and it's only applicable to physicians practicing in the United States. So what do we see, right? I think its strength, despite its lack of strength in methodology, is its scope and the ability to consistently compare across subspecialties. Some of the signals, when you look year upon year on the surveys, are pretty consistent, and some are not. All right, this signal is pretty consistent. Cardiology comes in because there's very little literature in cardiology, and so this is a major source right now. Cardiology comes in about the middle of the pack as of physicians reporting burnout, but their burnout is a single item question: are you feeling burnt out? Yes, right. Same signal again when it comes to males versus females, right? In all physicians, women tend to feel more burnt out than men. In cardiologists, the effect is about the same, although the numbers are a little higher. Women cardiologists feel a little bit more burnout. Are older or younger physicians more burnout? Once again, that same signal, fairly high, worrisomely high in young physicians. It stretches up to mid-career is the highest, right? And then as you go to 55 to 69, it actually starts to fall back again. What contributes to cardiologist burnout? The same theme appears: too many bureaucratic tasks, the increased computerization of practices, and spending too many hours at work. And the rest of it, I would say, are just a little soft beyond that. How do work hours correlate with burnout? And this is an obvious association. The more hours you work, the more burnout you feel, right? That's not universal, but it's true for a lot of people. The burnout by work setting, healthcare organizations, as we said, with the corporatization of what we're doing is the highest, then outpatient clinic, and surprisingly, or maybe not, office-based solo practice is the lowest rate of burnout, right? Despite the fact that only 20% of cardiologists in the United States right now are in solo-based private practices, those people that are holding out are actually feeling the best about what's happening. Which physicians are more likely to work long hours? Cardiology is almost at the head of the pack at 72%, right? And the definition of long hours, I think, is greater than 60 hours or more. Cardiologist Happiness, and there was a surprising discrepancy between the 2018 survey and the 2019 survey. Cardiologists in the 2018 survey were right at the bottom of the pack for both groups. Both at work and outside of work. There was 17% of cardiologists happy at work and outside of work for the 2018 survey. Somehow in that 1 year from 2018 to 2019, we moved up to the middle of the pack for being happy at work. I don't know, I can't think of anything that might have done this besides methodology. And outside of work, we remain at the bottom of the pack. So, and then which physicians are most likely to seek professional help? Cardiologists, once again, at the bottom. And the summary of the Medscape 2019 cardiologists: moderately burnout, relatively well paid, right? We're the second, I think, best paid subspecialty group. We work very long hours overall. We're tough, we're resilient. We hate bureaucracy and menial tasks. We're generally discontent with outside, non-autonomous administration. And we are moderately unhappy at work overall, relatively very unhappy outside of work. All right. So I think you have to ask the question then, so with all of this, right, what can you do, right? Is there anything that you can do? So this is from Maria Panagotti again from Manchester, right? And she did a systematic review to look at control interventions to reduce burnout in physicians. There were 75 full-text articles, 19 were included in the actual meta-analysis. There's a wide variation in interventions, but generally they were categorized as either organizational or physician-directed wellness programs, and there is a tendency to equate wellness, as we were talking about earlier, with burnout, and the two things are not necessarily similar, yoga, meditation, etc., versus organizational interventions, decreasing the amount of call that you take. Having a scribe on board, this, etc. And they found that overall, the organizational interventions were better than the physician-directed interventions. Both were positive, but overall, the treatment effects were small, equal to a 3-point reduction overall for the organizational interventions in the MBI emotional exhaustion domain, which has a scale between 0 to 54, right, if you use the traditional. So that's microscopic. And this is a summary of that finding. Their conclusion overall was these findings support the argument that burnout is rooted in the organizational coherence of the healthcare system, and that's why organizational change is probably the most effective, right? Leave us to figure out yoga for ourselves. I think it's fair to say. In the field of cardiology literature, there are only 3 or 4 sources, right? This is surprisingly one of the sources, and this is actually an Emory homegrown study published in Congenital Heart Disease, and it was a survey looking at burnout and work-life balance amongst pediatric cardiologists at Emory Children's Hospital, a single-center experience. And what did they find? Basically, Emory cardiologists are not burnt out. So I don't know. I think you're ahead of the curve here. In the areas of work-life survey, though, there were some dissatisfaction. 89% of people said they worked for prolonged periods of time, and 56% of people said, so much work, it takes me away from my personal interests. On follow-up interviews, selected follow-up interviews, EMR documentation burden and heavy clinical responsibilities were the major contributors of some of that. But amongst your 50 cardiology pediatric faculty members, most of which were actually general outpatient pediatricians, low levels of burnout. The big ACC, right? ACC obviously felt that they had to respond to this crisis, quote unquote, and they sent out a survey themselves, and this is the result published in the July issue of JACC this year from Lakshmi Mehta on behalf of the Cardiology and Women Leadership Council. And what happened, they sent out 10,800 surveys, 21% of people responded. They used the mini-Z AMA survey tool and not the Maslach burnout inventory, and that's a very important distinction. The rate of burnout that they got here was totally different from what we've seen so far. A quarter of cardiologists who responded to this survey were technically burnout according to the mini-Z AMA survey tool, right? Not the Maslach burnout inventory, which is the one that's been used otherwise. 73% of cardiologists said they weren't burnout, 24% really enjoyed their work, 50% were stressed but had less energy, and then 27% were burnt out overall, with 19% at least one burnout symptom, 6% were chronically burnt out, and 1% were completely about to crash and burn. Women, once again, more than men. Mid-career, once again. So these are very consistent signals despite the poor quality of literature, highest. People who are burnt out were less likely to be married. The subspecialty or work setting, whether you're in academic private practice, it didn't seem to matter. And the people who are not burnt out, 44% of them were likely to recommend cardiology as a career, which is kind of sad. I thought you would love to think that would be 100%, right? For the people for whom the jar is half full. But surprisingly, even those who were burnt out, 20% were still likely to recommend cardiology as a career. So we're still in the right field. This is some of the breakdown overall, and you can see that there's a relationship, obviously, with job dissatisfaction, with misaligned values, the no control over workload, insufficient documentation time, poor EMR efficiency, and the hectic work environment, very strong. So just working hard. When they looked at when they tried to break down independent associations, the people who were burnt out, no control over workload, hectic work environment, family responsibilities, hindering professional work, and the people who were not burnt out, things that help you are family life satisfaction, having a mentor as a role model, and feeling like they were being treated fairly at work, for whatever that means. We should organize, right, to try and fix this. I'm not going to stand here and say I have good answers for you. The Annals of Internal Medicine and the American College of Physicians probably has taken some of the important first step. They actually have a position statement on reducing administrative tasks and clerical burden. The American College of Cardiology, in response to the national crisis, has taken on the quadruple aim, right? In addition to the initial triple aim of improved quality and patient satisfaction, better outcomes, reduced costs, we have now added professional well-being as a part of your ACC being your professional home. Some pragmatic recommendations, I think, fundamentally as to how to get past. Improving efficiency of your EHRs is obvious, right? But that seems to be, for some reason, so difficult to surmount in our current environment. Providing support for those experiencing burnout, specifically with regards to women, I think that given the fact that we have recognized that they are at risk group, and appointing an executive level chief wellness officer at every healthcare organization. Although I have to say overall it looks pretty anemic based on what we're up against, right? But these are the fundamental recommendations thus far. The AMA has had this program here, the Steps Forward program. It's a program that gives you some tools and resources. It's probably the best toolkit for any of our professional bodies that we have. And you can go through it. There are modules, there's learning stuff, and there's one section here for professional well-being, and there's an entire section on physician burnout, but it's not much in it once again, right? Workflow, there's workflow, communications, targeted quality improvement, the different fields, and these are different ways you can do it, right? And probably that one in the corner is one of the most interesting, the shift to MA entering data into EHR instead of physician, covered in team documentation. Improve interpersonal communication. This is very much corporate speak. Does leadership matter locally? Mayo from Tate Chenenfeld once again surveyed all their departments and looked at how satisfied the members of each division and department were with their leaders, and they found that there was there's some correlation with how well local leadership is perceived. If you think your chiefs are good, you are more likely to be less burnt out. Although Mayo is probably not the best comparator because they're not quite like any other healthcare organization in the United States. Although this is probably a general truth, right? I just thought I'd put up a slide about scribes. At Emory right now it's ER, but no scribes at cardiology, correct? Yeah. Just starting, yeah. Yeah. At the University of Arizona, I introduced a scribe program in cardiology about a year ago. And I have to say, for my faculty, it has become the best thing, the most effective measure thus far for our general life satisfaction. It started in cardiology, and then it spread to the entire division of medicine, and has now rolled over into ENT, orthopedics, et cetera. We went from 1 scribe to 75 in medicine per week to 130 overall in the space of a year. And amongst our faculty, it's, there's been one randomized trial from Stanford Family Practice where they did 1 week on, 1 week off, scribe, no scribe, scribe, no scribe for an entire year. And they found that it improved all aspects of physician satisfaction in clinic, having enough face time, time spent charting, chart quality, and chart accuracy. The odds ratio of improvement here was 89.5 for time spent charting for obvious reasons. And the increased proportion of charts closed within 48 hours also statistically improved. There was no effect on patient satisfaction. Scribes, though, obviously are not the magic bullet, and there's a wide variation in scribe quality, and probably there needs to be quite a bit more research as to exactly how we effectively integrate them. If you hire a scribe, though, it costs money, right? The range in cost goes from about $14 per hour to $25 an hour, depending on the kind of scribes that you get. So just try and pull it together, to summarize. Cardiologists are facing new stressors as medicine changes. This is manifesting as quote-unquote burnout, although it is not well quantified or defined. In general, we should avoid bureaucracy as much as possible. technology should work for and not against us. I wish Apple would stay in medicine or Google stayed in medicine. They actually pulled out, right? The most effective solutions are going to be organizational, right? And driven by clear philosophical principles of what we are here for. Each sphere of burnout, it's a very complex idea, likely has different solutions, right? The depersonalized phase, the emotional exhaustion, those are all going to have different things. They are independent of one another anyway. Special attention should be focused on at-risk groups, such as women, given the growth of women in cardiology as well. There is vast potential for some form of organization to the study of burnout, and there's really a potential for ARC-like standardization and systematic study. I think it's always useful to part with William Osler. I think he's the voice that has really kept us true to our cause. You are in this profession as a calling, not a business, as a calling which exacts from you at every turn self-sacrifice, devotion, love, and tenderness to your fellow man. Once you get down to a purely business level, your influence is gone, and the true light of your life is dimmed. You must work in the missionary spirit with a breath of charity that raises you far above the petty jealousies of life. Thank you. Ars longa, vita brevis, right? The art is long and life is short. Questions?
Wonderful. So first of all, great presentation. Great to have you back here at Emory, and congratulations on the work you've done in Arizona.
Thank you.
A couple of questions. One, in terms of your scribe model,
Yes.
or elsewhere, how do systems pay for those scribes in terms of cost affecting the additional manpower and,
Right.
and I guess, of course, freeing up physician time to do more physician work?
Yeah.
At the highest level. And then the other question is, any data on, you go back to the RVUs, on compensation models, because part of it is our work is very different from what it was 10 years ago or 20 years ago, and how we define work is based upon only, what we say are billable services, but if all of our work was compensated, you might feel more satisfied.
Yeah, so those are phenomenal questions, and I really think they get to the heart of the matter. I'm going to split it up into two parts, right? We'll answer the scribe question first. So the way we justify, so right now, obviously, when you pull in scribes, the system asks you the question, should we allocate the costs right back to your RVUs as a deduction, right? For those of you who choose to have scribes. I think our healthcare system decided to just experiment, and the Department of Medicine just decided to experiment, first of all, by providing the scribes for free and seeing for a run-in trial period of a few months to see whether the increased productivity, the increased completion of note rate, and the increased access of care were going to justify it. And that was the last time we left it, and we were supposed to have looked at it 3 months into it, and it's been a year, and I purposely haven't asked the question again, but clearly it must be making a fiscal sense. I mean, if you think about the simple math, right, at $25 an hour, if you, instead of seeing 3 patients, you see 4, it makes up for itself instantaneously. And what we did was, as a criteria for getting a scribe, we set minimum rates of patients being seen in clinic, right? So if you were, but then how do you deal with then the discrepancy of some people who naturally see more patients in clinic versus those who don't, right? Do you make some adjustment? We have not, right? We just basically said this is the minimum number. So those of you who are already high volume providers, this was just an added benefit of buying back some of your free time. Those of you who are low volume, look at those other guys. Do you want to get there, etc. So we haven't really, I've purposely not asked the question just because of how happy my faculty are, and I don't want to know the answer. But if you just do the math in your head, it totally works out, as long as it does result in a slight increase in volume, right? Does it allow me to then schedule physicians to do other things? We've never studied that in our system yet, right? More productive things, I don't know. Your second question, that's just really hard, right? We have an RVU model, you know, from the basic model when I started at University of Arizona 10 years ago, where we were essentially salaried, to Banner Health coming in and trying to impose community practice RVU standards onto an academic workforce. It's been a disaster, to be honest with you. So much is lost, right, in the equation. And I think part of the dissatisfaction overall with this is how exactly are we expected to teach people? There's never really been money in the system for teaching medical students, for teaching residents, for teaching fellows. Most of us who decided to become academic cardiologists understood from the very outset that it would come at a cost. We do it because we love it. We do it because it makes us feel whole, and it is necessary for the future of our profession. And then you come in and you hoist these productivity models, and some executive standing in the back saying, "Why aren't you seeing 4 patients in clinic?" Right? Well, because I'm supervising 2 fellows and I have 3 medical students. So as we try and do the fuzzy math and make the equation balance, this is one of the fundamental reasons for our current dissatisfaction. There must be somewhere along the line some recognition of that time. Right now, I know there are a lot of healthcare systems in the United States when it comes to cardiology that will reimburse for taking STEMI call, right? And that's a big discussion at the ACC level, the SCAI level, et cetera. But we have never been reimbursed for call. And yet, when you look at the disparities across our system, urology gets $1,000 a night for call, right? ENT, but not interventional cardiology. Why? Because it's expected of you, because it's part of your job profession when you sign on, is your RVU reimbursement rate. That may have worked before when the RVUs for CAFs were very high, but in the modern era where those numbers are falling rapidly, that doesn't quite add up. So we are lagged behind in what we, the concept of TVUs, right? Time value units instead of RVUs, right? And also, like, how do you then compensate someone who you ask to go to a new hospital, say some small satellite hospital? You need to man the system, but there are not that many RVUs there, and yet you're sitting there. What do you do with that? There's great disparity in that. So no, I don't have good answers for you, but I think those questions hit at the center core of what we're struggling with. Yes.
Thanks for a great talk. So one thing I want to say is just an observation. So one of our subspecialties here in medicine, which I'll leave unnamed for the time being, basically all of the full-time clinicians have cut back to a 0.8 FTE.
Mm-hmm. Yeah.
And they have the highest satisfaction
Yeah.
on our survey when they do our institutional, satisfaction survey.
Yeah.
And I think that's very telling. It just says there's just a ton of work, and
Right.
and it certainly hits cardiology hard, as you pointed out. We're always in the top 2 or 3 in terms of hours spent, and I do think the one thing I've never seen, and perhaps you have. That's my question is. And it alludes a little bit to what Larry was saying, is work RV productivity-based models versus non-productivity-based models. Have people looked at that carefully?
No, not in the context of burnout.
Because that seems like, here I am as a division director feeling very guilty about this because we're a productivity-based model, but that's been our model for 15 plus years, and but I do think it drives it, and and part of it is ourselves. Right. And part of it is the system we impose. So, right. So I think that's something that's of interest. The scribe issue, I'll tell you, we're struggling with it. So we wanted to have a broader scribe issue. We had to negotiate a pilot, thing with the institution, and we're getting the same questions. Oh well, what are you going to do to validate this? Right. As viable. And
it does require some investment. I mean, are you going to hoist the cost back to the provider, or is the department?
Well, it goes to the group. I mean, it goes to cardiology, but we're not assigning it to individual providers for the initial pilot. And ultimately, I think that's a big solution.
Yeah.
And so we're hoping this year to get a little toehold on that. And I think we have to formalize a little bit. But the question we get from administration is, well, where's the cost benefit on this? And I kept saying, well, the cost benefit is maybe you won't lose one cardiologist in the
Right.
next 2 years,
Right.
and that would wipe out your entire.
Yeah, I think that's the
deficit.
real difficulty with modern U.S. healthcare, right? All these people that are making decisions, you never see them in your clinic. You never see them on call with you. They have no idea what it takes to look after a person in clinic, right? And yet they get to make the decisions as to, and they don't seem to look at us as important individuals that are key for access to a much broader panel of patients. For every physician that you lose all those patients that come with them. And if you add up the facility fee profit, so I did a bit of deep diving into my healthcare system because they said that our contribution margin in cardiology was low, right? In clinic, operationally, we were, for our 24 faculty members, $1 million off for the year. But when I actually went into the books and looked at how much money they collected from the cath lab, from the, from the echo lab, you're looking at almost, what, $50, $60 million per quarter in facility fees. In a private practice business model or any kind of business model, those two things are tied together, right? Any money that you make on that end, right? Who cares about $1 million operational loss in clinic, right? That's how most private practices work it out, That's how they can staff themselves up. The busiest provider in town sees 50 patients per day, but they have scribes for each room, right? They have 4 scribes operating all at once, and the patient comes in, and an army of support staff, et cetera, and then, preaching to the choir.
I guess just your comments around how to define this on a more basic
Yeah.
level. So loss of control, overburden of time, the impact of electronic things other than what we have to do. That is, we get email reminders on weekends of things that we have not done. Things come out at midnight.
Yeah.
We're checking email constantly, but and I appreciate maybe Neil Dickert's thoughts on some of this. We've had discussions around residency training and the decrease in hours that residents have that actually our current residents may be under more stress than I was when doing 115 hours as an intern at Grady, but having some downtime sitting around in the call room talking with my colleagues. So this idea of community and whether some of the satisfaction in private practice is that you have more direct community and control and not necessarily whether it's tied to the finances. And whether finances, specific rewards, how much do they really matter, or is it just a feeling of that you want to be treated fairly within a system? And there's a lot of things as I look at my career that I have been uncompensated for, and even in doing charity work that I feel
Great
the
about.
best about, but it
Yeah.
also helps me appreciate what I have within my work. So
Yeah.
some of these things, it sounds like that we're jumping to solutions without really looking into the root causes and how we address those root causes.
Yeah, I think your point is well taken. Getting paid more is not the answer out of this, right? Esprit de corps is very important. I think Daniel Pink, right? His 3 things, right, that bring people to the fold and have them work happily and for free. Wikipedia being one of the best examples. A, the sense of autonomy, right? You have control over what's happening around you. B, a sense of beneficence. The thing that I'm doing is resulting to some good in the world. And, the C, the sense of mastery. I'm getting better and I'm good at my job. If you allow people to feel these 3 things, you move the world, right? You don't need massive salaries, and to your point, and that's why a lot of people are just happy, get administration off my back by cutting back to point whatever. get paid a 1-to-1 fair ratio for your RVU. Don't taxate me unreasonably, but just let me just work and be a regular human. I think the problem for my end in some of our academic faculties that they are the first percentile in productivity. There is a point at which you drop to your point, whatever RVUs, where you no longer get benefits. And, and yet they cannot adapt to this new world of high volume from the old model. And yet these are very, distinguished people who have a great lifetime career as educators, et cetera. How do we bring them in? I don't know. I don't have answers to that.
Guess I have to say something. Yeah, the couple of things that just come to mind, because there's a form of things, I guess, I'm always persuaded by, for me, one of the most salient studies I've seen is the old Whitehall studies that look at, social determinants of health, and the group that does poorly is the group that has essentially high responsibility and low control.
Yeah.
Right, so I think that sense of feeling like there's tons of responsibility hanging on you, and not a lot of control over how you do what you do is certainly, I think that drives a lot of the residency piece, right? When people are in really circumscribed work hour environments, they don't have the time or space to think through things and engage in ways that maybe people did in the past. And it's not that everything used to be right, but there's certainly things that maybe aren't quite optimal now. I guess the other tension that seems to me really interesting with regard to the earlier part of your presentation is, a lot of the movements towards constraining practice, it seems to me they divide in two types, right? One are really interesting and I think potentially positive movements towards trying to improve quality of care and cost effectiveness of care. The other are the administrative burdens that don't
they don't
advance
do anything.
either of those
Don't
missions.
do anything for
And I do think it's true that both cause stress and both cause a need for change. And I think figuring out how we can properly incentivize movements to accommodate the former and maintain the things that are important while we eliminate as much of the latter as we can. That's not more than, that's not a great observation, but I do think that they do fall into both categories, and it's important to separate out what's what.
I think a large unaddressed thing or an issue is also how patients as the Tamagotchi, right, are modeled in the modern electronic health record, vastly underappreciated, right? Part of the reason why our residents and fellows or medical students spend all that time sitting in front of a computer is because the patient as a intellectual construct has become far more complicated, right? In the older days, without all that EHR, you walk into a room, there's just a history that you take from the patient. You look at the patient. I have chest pain, great, right? Nowadays the patient has 4,000 records in Cerner, which are not organized in any cohesive fashion, right? You have labs stretching back forever, and your attending might pimp you, or on the question, when was the last, they got a calf in 2007. What was the stent that was put in which artery, what vessel? What wire did they use, what guide? So there are all these information tidbits now that are hidden in a non-organized fashion within the EHR that our residents are struggling to contend with. And so at the U of A, I actually teach a course for all the incoming medical students on exactly what is the most efficient way to data extract and reconstruct a patient that you have never met before, right? How do you go about reading that massive tome of information? How do you organize that information to make it a cohesive, coherent, functional whole? And I've never seen a medical school in this country which has decided to really address this as a fundamental skill set. You could argue in 2019 that is more important than your current ability to examine a patient, right? Forget the hard sounds. Sorry, I'm just being, but you get where I'm going.
All right. Thanks so much. Thanks.
The preceding program is copyrighted by Emory University.